So, good morning, everyone. So, as for the continuation of this uro-oncology, previously we have discussed the superficial bladder tumor and the management with the TUR, BT, and the other options. So, today we will be discussing about the majorly, we will review about the staging workup and then about the radical cystectomy and the partial cystectomy. So I think it's 8:15. So we are going to start the club. Yes, sir.
Assalamu alaikum to everyone. I am Hamza Abdul Malik and my moderator is Dr. Abdul Khalik. So today I am present the General Club meeting and my topic is muscle invasive bladder cancer. So today our objectives is staging, medical radical cystectomy, bladder sparing strategy, and last one is key points. So, in the previous lecture, we discussed in detail about non-invasive blood cancer. So, this is the TANM classification, in which muscle invasive staging, the T2 to T4. So, in this diagram, the T2A is when the tumor is involved superficial muscles, and when tumor is involved deep muscle is T2B. And when the tumor is involved, the perivesical fats, micro and macro division, the staging is T3. And when the T4 is when it's involved in male prostate and seminal vesicle in female uterus and vagina, then we consider the T4A. And when it involves the pelvic wall, the staging is T4B. So this is the EU guideline chart TMA classification as we discussed before in diagram. The TMS classification and in node, when the TX is regional lymph node cannot be assessed, no regional lymph node metastasis. Like in M is distant metastasis. M naught is no distant metastasis. 1 and M1B is the distant metastasis is occur. According to the pathology of muscle invasive bladder cancer, the 90% is the urothelial cancer, and the 2 to 5% is squamous carcinoma, and 2% is adenocarcinoma, and 1% is neuroendocrine, and rare tumor is less than 1%. So, what are the recommendation of staging of muscle invasive bladder cancer? The inpatient with confirmed muscle invasive bladder cancer use the CT scan, abdomen and pelvis for staging, and including some form of CT urogram for the optimal urothelial evaluation. Use MRI when the CT is contraindication, and the CT and MRI for staging the local advanced and metastatic disease. Use CT to diagnose pulmonary mets, and the CT and MRI to generally diagnose the local disease and distant metastasis. So next is the disease management in neoadjuvant therapy. The neoadjuvant cisplatin contain combination chemotherapy improves overall survival 5 to 8 at 5 years. Neoadjuvant chemotherapy have a favorable pathology when the patient is PT1 and PT and not, and the surgical margin is negative. The response after 2 cycle treatment is related to outcome. There is another enhancement in the genetic marker checkpoint inhibitor and the platinum PDL1 for the trial basis studies to improve the disease and the outcome of the disease, but the research is going on. For the recommendation for the neoadjuvant, offer the neoadjuvant chemotherapy for the T2 to T4 non-muscle muscle invasive bladder cancer in case of always the cisplatin based combination therapy. Do not offer the neoadjuvant when patient with not eligible for cisplatin. Only for the neoadjuvant chemotherapy with a clinical trial setting. Do not offer the pre-operative radiotherapy when we plan for the radical cystectomy. consider the offering the adjuvant radiation in addition to chemo follow of radical cystectomy based on the pathology is PD3B and PD4B and the positive nodes and the positive margin. So, in surgical management of bladder cancer, we detail and discuss in previous lecture, original club, TURBT, resection of tumor, and but now we discuss about the radical cystectomy and the partial cystectomy. Radical cystectomy, the first, the Burton Howard German surgeon performed the first cystectomy in 1887 and the first modern technique for radical cystectomy in 1956 from Buchan and Marshall. From the beginning, the radical cystectomy is performed from perineal exploration and the dissection of the rectum from the bladder and the prostate under duct visualization and the cutaneous urostomy for the division is formed.
The radical cystectomy. Can anyone tell us about what are the indications for neoadjuvant chemo, or does all patient needs neoadjuvant chemotherapy before radical cystectomy, or are there some indications? कोई पर्टिकुलर इंडिकेशंस हैं या सब पेशेंट्स में आप neoadjuvant देंगे?
So not all the patient need neoadjuvant chemotherapy. It is given when there are lymph nodes are involved, and 1 or 2 lymph nodes are involved.
We usually give neoadjuvant chemotherapy to the after initial workup like pathological and clinical staging, and the aim of neoadjuvant chemotherapy is to downstage pathological staging as well as to regress micrometastasis. So if on the CT chest, abdomen, pelvis with contrast lymph nodes are positive and patient's renal functions are within normal parameter, so we can give the neoadjuvant chemotherapy followed by radical cystectomy.
What are the chances of how much chances of increased recurrence in patients who receive the
what are chances of recurrence in bladder cancer?
How much chances increase in patient who receive the
it's overall radical cystectomy is gold standard for muscle invasive bladder cancer, while neoadjuvant followed by chemotherapy. The different data and literature suggests that is the comparatively better, and 5-year survival is better in patients who received neoadjuvant chemotherapy.
Are there any chance of disease progression during the period of this neoadjuvant chemo? या सब में मतलब डाउन स्टेज होगी डिजीज then go for radical cystectomy, या कोई ऐसे चांस भी है किसी पेशेंट्स में कि वो ड्यूरिंग neoadjuvant chemo disease progress हो जाए and the patient before radical metastasize हो जाए? Are there chances or not?
I think don't think so. The reason behind is that the neoadjuvant basically downstage the pathological staging.
Anyone else? So it's not always that you got the positive response of neoadjuvant. This is one of the point that where you should not use this neoadjuvant chemo. So it's not always it downstage the disease. Sometimes patient does not respond to this neoadjuvant chemotherapy, and disease progress your this period of time in which you offer them a neoadjuvant chemotherapy, and the patient got the metastatic disease at the end of neoadjuvant chemotherapy. This is one of the disadvantage that not always all the patient needs this neoadjuvant chemotherapy. So this is some advantages and disadvantages. Then you should decide about the neoadjuvant.
So, what are the indications radical cystectomy in non-muscle invasive tumor. The T1 with high risk features and T1 grade 3 with multiple tumor, T1 grade 3 with diverticulum, recurrent T1 with grade 3, BCG refractory diffuse carcinoma in situ, and the extensive papillary disease that cannot be controlled with TUR and intravesical BCG, T1 high grade and incomplete resected, and prostate and the bladder neck cancer. The muscle invasive criteria for the indication are the T2 to T4 disease, and other are the non-urethral carcinoma like squamous and adeno, and the partial cystectomy non-responder to conservative therapy, and the recurrence after bladder sparing treatment, palliative intervention like fistula pain and recurrent microhematuria. So after the decision of radical cystectomy, first we take consent for this procedure. The patient is explained about the disease and the diagnosis and its prognosis, the need of the surgery and is a 5-year prognosis, and which organ is removed in male and female, and all about the other diversion like ileal conduit and the complication and the ligation of the vas deferens, and in future like in male erectile dysfunction and general complication like infection, bleeding and trauma. So pre-operative preparation after decision of the radical cystectomy, we all go through this procedure very well to prepare our patient for pre-operatively. After taking consent, we take detailed history of our patient, general physical examination, and then basic labs. And after this, for prepare the patient for next procedure, arrange blood, and some of the study equivalent between the liquid diet start before 1 day before the surgery, and some study said okay, there is no major difference between when you start the liquid diet before a day surgery. And the marker site for the ileal conduit and the other diversion, the inform the pathologist for the frozen section. So the main step for the procedure is first to start from the position in CN, abdomen exploration, ball mobilization, urethral dissection, pelvic lymph adenectomy, ligation of the lateral and the posterior vesical pedicles, and the interior apical dissection. So on table, the position in male patient placed in spine with the flexion point of the table at the level of interior spherical spine, and the flexion point is the 50 degree. It can be less if the patient any spinal fusion and lumbar injury. In the woman, the position is low lithotomy position to provide access to the vagina, and the operative field of the abdomen at the level of the xiphoid to the upper portion of the thigh, and the genital organ including vagina in women, and the pin should be prepared as well. So start from the incision. We take the lower midline incision, which is extended distally to the pubic symphysis and the pelvis superiorly to the umbilicus. And the fissure is divided and approach the radius space with the space between the bladder and the blood dissection start to release the bladder on the both sides of the pelvic wall, and the incision or in the peritoneum to the laterally to the medial umbilical ligament, and at the level of internal inguinal ring, at which point the vas in man and the round ligament woman will be identified and divided. The bowel mobilization is achieved great exploit for the great vessels and the ureter. On the right side of the line of thought, we follow and around the cecum, we posterior peritoneum inside and allow the mobilization of the small inside mesentery. And the same on the left side, follow the line of thought and create a window in sigmoid clone. And this is usually this space will later used to the transmission of the left ureter to the right quadrant and for the urine diversion. So after the exploration, we add a bookworm detector for the maximize our exposure. Before this, after place this detector, we should communication with the anesthetic because there is a this thing in our mind, there is a compression of inferior vena cava and the aorta, and we putting this pads should be placed behind the director plates and protect the abdominal contact. With our eyes on the monitor is very necessary. So after adequate exposure is achieved, the bilateral ureter are dissected free from their attachment and being a few centimeters above the cross iliac artery at the level of hiatus. Umbilical artery should be ligated and divided before completing the ureteral dissection. And the distal ureteral margin sent for the frozen section to see if there any presence of the ureteral carcinoma or not. So move further for the pelvic lymph adenectomy. Perform the anatomical boundaries consider the genitofemoral nerves, lateral and the internal iliac artery, between the cooper ligament and then fili at the point with the ureter cross the common iliac arteries fili. And in case of advanced disease, we done the extended dissection and entire the common iliac lymph node and the parasacral lymph node pocket. And the inpatient with at least 10 lymph nodes were moved, the 5-year survival improved from 44 to 61%. So this is the diagram showing the lymph node anatomically with the common iliac veins and different points. And there is the different limited pelvic lymph node dissection, and there is the extensive lymph node dissection. The marcation is in this diagram. So after completion of the pelvic lymph adenectomy, the identification of the vascular pedicles to the bladder and the control to aim the branches of the blood including the superior, middle and the inferior vesical arteries. So this is some difference between the radicocystectomy in male and female. In male, the anterior vascular pedicle blood supply is completely ligated to the turn to the posterior dissection, and the rectal AD sacs is identified, and the peritoneum is incised where it overlies the seminal vesicle, and the rectum is dissected and free from the blunt dissection and the midline at the level of prostate. Actually, the point of Dinovilus fascia is encountered and incised. This is the diagram we discussed before. After completion of the posterior dissection, the urethra should be palpable at this point, and return to the anterior dissection, and the endopelvic fascia or lying the levator muscle is inside sharply and between the urethra and the dorsal venous complex, and the ligation and the division of the dorsal venous complex allow the visualization of the anterior urethra when it is incised. So this is the dorsal venous complex. In non-nerve sparing is performed choice in advanced disease and the patient with the pre-existing erectile dysfunction. In female, the radical cystectomy is the anterior pelvic section, and then clear the bladder, urethra, anterior vagina, uterus, and cervix. And the initial step, same in use in male, the mobilization of the bowel and the anterior bladder and uterine dissection, and same in the female. The ovarian vessel should be identified and during the ball mobilization and ligation with the silk suture, and with the proximally and the distally, and then divided. Interior pelvic, the identification of the posterior cervical forehead and the vaginal cuff is incised at this position. After beginning the entry in the vaginal canal, the surgeon easily control the lateral and the posterior muscular pedicle to the bladder, and the specimen dissect from the uterus and cervix and the interior vaginal cuff of the bladder, and the uterine meatus is then incised, antegrade, and externally to the vaginal interstices, and the specimen is moved. So after completing the vaginal closure, the posterior vaginal flap is closed and cross-mounted to the clam shell fashion, and the vaginal packing is placed with the dual purpose of the descending and the vagina, and for the providing the temporary effect for the residual vaginal wall hemorrhage, and the packing removes 2 days post-operatively. This is showing the vaginal posterior wall, anastomosis sutures. This is a short video.
Your doctor has recommended that your bladder be removed. This surgery is called a cystectomy. In men, complete bladder removal includes removal of the prostate. In women, complete bladder removal typically includes removal of the uterus, ovaries, and part of the vagina as well. To remove the bladder, the surgeon must separate both ureters from the bladder, the tubes that carry urine from the kidneys to the bladder. The surgeon will also separate the urethra from the bladder. The urethra carries urine from the bladder out of the body. During the procedure, the lymph nodes may be removed as well. Once the bladder is removed, the surgeon will need to make a new way for passing urine from the kidneys to the outside of your body. This animation shows the 2 most common ways to pass urine: the ileal conduit and the Neo Bladder. Type 1. The ileal conduit. The ileal conduit is a new tube to carry urine. It is made from a section of your intestine. The conduit runs from the ureters, the tubes that carry urine from your kidneys, to an opening in your belly, called a stoma or a urostoma. Urine is collected in a small bag placed over the stoma. The bag will need to be emptied when it is full. You will be given instructions on how to change the bag. Type 2. The Neo Bladder. A Neo Bladder, or new bladder, is a pouch created from a portion of your intestines to store urine inside your body. The ureters are connected to one end of the Neo Bladder. The urethra connects to the other end, just like in your original bladder. You will pass urine through the urethra. Follow-up care is provided by your doctor or a specialist nurse after you leave the hospital. This will include educational lessons.
So the radical cystectomy is not always the simple one that has been demonstrated, but the minimally invasive surgery has been involved in this procedure, and I think it may have got its benefit. So, Dr. Harris, you have an experience of this surgery with the minimally invasive procedures. So, does it make much easier with the access with the robot or laparoscopy, or are the same in terms of outcome or in terms of surgical steps?
Once I asked a robotic surgeon that can this case be done with minimally invasive surgery. So his reply was any case which can be done with open surgery can be done with minimally invasive surgery. We were talking in context of a patient being previously operated. Will you go for a minimally invasive surgery? So I guess a lot of people are doing, and we are also doing minimally invasive surgery, robotic surgery for bladder cancers and cystectomies. But internationally, if we still see the trend is towards open cystectomy as a gold standard. For prostate, yes, robotic surgery. For partial nephrectomies, yes, robotic surgery. For radical, yes, plus minus laparoscopy. But for bladder cancer, still there is a school of thought which says that open should be done, and till the latest guidelines, they also recommend that it should be done minimally invasively. When Dr. Khurshid Guru came over here and he performed interior exentration completely robotically, and he performed that ileal conduit as well as robotically. So that was a turning point in our vision that these things can be done completely robotically, and the patient had good cosmosis and would discharge early, less blood loss. He removed that specimen of that female from vagina, and only there were 3-4 ports and an ileal conduit which could be seen. There was no big incision on the patient's belly as well. So yes, it can be done and it is being done, but we have over here performed ureterostomies and one intracorporeal suturing of that conduit as well. So expertise are needed for that, practice is needed, and yes, it is doable and it has got better results. But still, the gold standard for cystectomy is open to date. Sid, what's your take?
Yes, I fully agree with Haris. But the thing is, you have to understand the basics first. They are not changed. Whether you have got a robot, whether you know how to do it through laparoscopy, these are just tools. One has to know what's the pathology. One has to know how it is being done properly anatomically, and that is through open surgery. It doesn't mean that in this day and age open surgery is out, because some of the people who are at the back of this hall, they still think that we are actually some way behind, because we are always prescribing something on an open platform, and the things have changed over the years in the outer world. But the thing is, if they read it properly and they read it deeply, every subject, every pathology, every topic in operative surgery, in urology and in general surgery as well, is actually compared with open surgery. Whether you make some advancement in technology, you come up with laser, you come up with anything which is like ultrasonics, it is always compared with the gold standard. The gold standard hasn't changed. The gold standard is you have to know the basics of anatomy. If you don't want to know the anatomy and if you want to just predict on the basis of a radiological report that what the pathology is, and you want to play like you play in your bedrooms and in your lounges, a video game. So this is not a video game. So please don't be carried by whatever is being propagated on the social media, on Twitter or Facebook, unless and until you compare it with a textbook. So the textbook knowledge hasn't been replaced yet, and it will not be replaced in near future.
The slide over here with the nerve sparing techniques. So the basic principle of nerve sparing should be always that the tumor should be removed completely, rather than saving nerves. You leave the tumor behind. This principle should always be in mind. And when Dr. Badar Mia came over here and we were doing prostates with him, and we discussed that a lot of nerve sparings are done in USA, and what is your take about it? So he gave this concept, and that was a very valid concept, that don't go after fancy things. You oncological control comes first, then these controls you have to take care. And then he asked us that was the biopsy taken from that side where we have to save the nerve, and was a tumor on that side, and their way of thinking was a bit different from ours, and we started modifying our way of thinking. So we learn from others as well, but always rule of thumb is oncological control first, then these things come.
You see, robotically assisted radical prostatectomy and robotically assisted colorectal surgery, they have been compared with the open surgery, and the results are open surgery is still better than robotically assisted surgery in both these two pathologies. But again, the problem is whenever there is a news, the news is taken by the journalist, and the students, they tend to follow the journalist rather than a senior professor. So this is the kind of a world that we live in. We always go by the hunch, not by the fact. The fact still is you have to compare coin with a coin rather than coin with the head.
Thank you. So the oncological control is very important in this type of surgery, rather than doing some fancy procedures like in patient who has advanced disease, and we are going to perform this procedure in those patient who has advanced disease or some perivesical fat involvement on that side, and pelvic wall involves. Many of patient that we have performed for a PT2 disease, and we found peroperatively that the disease is involved the pelvic wall clinically on peroperatively. So you need to decide about your procedure thoroughly. So continue.
Dr. Abdul Khalik, I have a question.
Yeah.
Usually in our center, in our setup, we are using radical cystectomy, that is the standard radical cystoprostatectomy. But in the patients who are indicated for nerve sparing radical cystectomy, we have different, like we can go for the nerve sparing or capsule sparing or prostate sparing. And a patient has concern about his erectile dysfunctions as well. So what's your take on what should we do and how we can do it?
So, Dr. Asad.
Yes, I can answer this question very well, because you see, to go up to the stage when you can safely and with confidence tell your patient that you need surgery that might be possible with a nerve sparing procedure. We are talking about cystectomy, and or maybe capsule sparing, or as we have said, prostate sparing. You need to have a lot of cystectomies done at your center. Still, we are far behind that kind of a number, which is for a high output center. We can satisfy ourselves that we do 1 or 2 cystectomies in a week, but that is not enough. People have done, because there are centers in the world, they are doing it at least 2 to 3 cystectomies a day, and that is Mansoura in Egypt. Now, if they come up with such a kind of an algorithm for their own patients, then they are justified. We will not be justified at this point in time. We need a lot of experience and a lot of patients done through our own hands, through our own say unit. So still we are far behind that kind of an activity.
And we have got different patients, and we have got a lot of advanced disease as well. So this slide, the first thing which is written, that the treatment should not be delayed for more than 3 months. That is a very important point. And if that treatment has been somehow delayed after 3 months, then that patient should be restaged and CT scan should be performed and everything should be seen. A lot of patients we see when we open up, and we were expecting that this is a bladder confined disease, and we find that it is completely adherent to the pelvic walls. And we have to be very vigilant regarding our staging and timely surgery, and we have to improve these things. Then after a certain experience, then you can go after that. First you have to do the basic things, we have to do our homework on the basic things, and as Dr. Asad has said that anatomy and these things should be read thoroughly, that how this all things work, because you can't go for a nerve sparing surgery without knowing the anatomy and the basics of the patient. So first you have to pick up those patients, then you have to do your homework, you read about it and learn those things, and then you can perform it, but it needs experience.
I think there is this prostate sparing and genital sparing in females and prostate in males is an option for younger patients. And but for example, prostate can be saved to save the sexual functions in those patients whose urethral biopsy is negative. Okay, and especially if the female is in the reproductive age and they want to preserve their genital functions, the reproductive function, then this may be an option in an experienced hand, as Dr. Asad said. But we have to be sure that the disease is not outside the bladder in these patients. So this is an option for the younger patient, especially who request the surgeon that I want to spare my sexual potency, my reproductive potential. Then this can be an option, and there are some series with limited number of patients who have reported the survival rates.
Thank you. So, what are the recommendations? So, do not delay radical cystectomy more than 3 months because it increases the risk of prognosis and mortality. And unless the patient receives the neoadjuvant chemotherapy and perform at least 10 and preferably more than 20 radical cystectomy per year. And before radical cystectomy, fully inform our patient for the benefit and the risk and the possible alternative and the final decision between the patient and the surgeon.
Asad, can we discuss what are the advantages of neoadjuvant therapy?
Previously, yes, we have discussed.
We have discussed?
Yeah, we have discussed.
Already we have discussed.
Yeah.
Okay.
So, do not offer the Neo Bladder with the substitute or diversion to patient who have a tumor in urethra and a level of urethral dissection. And do not offer the sexual preservation in the radical cystectomy to man as standard therapy for muscle invasive bladder cancer. Offer sexual preserving technique to men motivated to preserve their sexual function, since the majority will benefit.
If a patient comes to you with, as Manzoor sir has said, in a younger age with the disease which is like muscle invasive, and who wishes to have the sexual function intact after such a radical surgery, now the onus then lies on you as a clinician or as a responsible person, because if then you are carried away by the wishes of the patient, then you are not justifying at least your presence, and you are not also justifying the definition of or defining the disease properly to the patient. So it's your responsibility that the whole spectrum should be in your perspective, and you should discuss all the pros and cons, because if you preserve sexual function and you leave the disease behind, there is no point in it, because the person will not be able to live. Muscle invasive disease, the survival for a person is between 6 months to 2 years, not more than that. So it's rather odd that you try to figure out something for a person who is at such a survival point. So you have to be very, not only very conversant, but also very much with the science. So you should not sacrifice science in the favor of somebody's wishes. So that's my take on this subject.
But I think to preserve the prostate, urethral biopsy must be negative.
Yes.
And involvement of, for example, uterus, vagina, and ovaries must be negative on the whatever imaging technique if you want to preserve.
The selected man for sexual preserving technique based on the organ confined disease, absence of any kind of tumor at the level of prostate, prostatic urethra, and the bladder neck. Do not offer the pelvic organ preserving in radicocystectomy to women as a standard therapy for the muscle invasive bladder cancer. Same as in offering the sexual preserving technique for the motivated preserve their sexual function, since the majority will benefit. Same as that. The selected women for the preserving the absence of tumor in same or avoid positive soft tissue margin and the absence of PT for urethral carcinoma. Preoperative bowel patient is not mandatory, and offer pharmacological prophylaxis such as low molecular weight heparin to radicocystectomy patients start the first day post surgery for 4 weeks. Offer radicocystectomy for the patient T2 to T4, and the lymph node and the metastasis is not and the high risk non-muscle invasive cancer. Perform a lymph node dissection as an internal part of radicocystectomy. Do not preserve the urethra if margins are positive. So what are the recommendations about the laparoscopic and the robotic? Inform the patient of the advantage and disadvantage of the open and the robot assisted radicocystectomy to allow the selection of the procedure. The select the experience center, not specific technique. Both are robotic and open. So this is the chart which showing the management at which we discussed before, and follow the patient with the cystoscopy and the evaluation and the CT with the chest and pelvic, and then MRI for the staging. If the finding is T4 to T4B, then go for the radical cystectomy, either male and female, and the new agent chemotherapy, the 5 to 8 years benefit for the accommodation of cisplatin. And the radical cystectomy, as we discussed for the before the doing radical cystectomy, we prepare our patient surgical technique and all pros and cons discuss with patient. The other portion is the partial cystectomy, the bladder sparing surgery in the setting of muscle invasive urethral carcinoma require the proper patient selection. If the lesion is solitary and the small size and the lack of concurrent carcinoma in situ, the result from the partial cystectomy are the similar for those for the radical cystectomy. And the study which showing the match of the surgical quality, move of the lymph node, and the clinical pathology features in the partial cystectomy was equivalent in terms of overall the cancer-specific survival. In the patient with the organ confined disease, 5-year survival is 60%. Otherwise, that's 7% if the disease is extravasate. As going to the partial cystectomy, we prepare our patient, start from the counseling, and for the radical cystectomy, it's if needed, and then diversion and the partial surgical removal of the lymph node adenectomy, as well as the interior wall mobilization, and the major thing is the cystectomy is performed at the area away from the tumor, and the tumor is in size, including the underlying the bladder wall and the periodic fat, the mucosal margin 1 to 2 centimeter confirmation, the resection adequate with the frozen section. Is it possible or not? If necessary, the urethral orifice and the intramural urethra can be excised and the replant again. After excision of the tumor, the cystectomy is closed with the suture in the two lining and the installation of the Foley catheter and perform the water closure and start the irrigation in the surgical field to perform the minimize the pelvic seeding and the close the drain. We perform cystectomy and if needed the bladder augmentation if the capacity is very small. So they use the ILL conduit and ILL and for the increase the bladder capacity. And before of course separately before moving the cystectomy we do the cystogram. So, what are the recommendation for the bladder swing surgery? Do not offer this the transurethral resection of bladder tumor alone as a curative treatment option. The most patient will not benefit. Do not offer the radiotherapy alone as a primary therapy for the localized bladder cancer. Do not offer chemotherapy alone as a primary therapy for the localized bladder cancer. Offer surgical intervention and the blood sparing to prevent the candidate as a primary curative therapy approaches. They are more effective than radiotherapy alone. The partial the alternate selection for the well-informed and the compliant patient, especially for whom the radical cystectomy is not an option or not acceptable. So the key point of our presentation is the optimal treatment of the muscle invasive bladder cancer require a multidisciplinary approach involving of the uro-oncologist, medical oncologist, and the radical oncologist. And the gold standard is still is if the patient is muscle invasive bladder cancer, that is the radical cystectomy with the neoadjuvant cisplatin-based chemotherapy, and the bladder preservation with the chemoradiation therapy has become an increased popular option in muscle invasive cases. Despite all this thing, the 50% of the cystectomy patient will ultimately die of disease. And the meta-analysis of this systematic cisplatin-based neoadjuvant chemotherapy trial has demonstrated the modest and the initial response rate is a cisplatin-based chemotherapy is the metastatic setting as the favorable for the patient. Thank you.